Like everyone else, I want to thank the organizers of this really interesting conference for inviting me. It's just been a really fascinating day, and I think I've learned a lot. So I'm just a bioethicist. I'm not a neuroscientist. I have no special expertise on that, I guess. But I do want to talk about bioethics and sort of how bioethics has approached disorders of consciousness. So to say that persons with disorders of consciousness have been marginalized is really an understatement. They're not even really on the outer bounds of the margins. They're really completely outside the margins. And almost since the vegetative state was named and defined, patients in the VS have really been considered hopeless cases who inspired the right to die movement and who occasionally get a lot of attention because of end-of-life conflicts that end up in courts. And there is still a great deal of philosophical and ethical debate about whether or not they have any interests, let alone best interests, whether or not they are persons who have moral status, whether or not it makes any sense to use medical and financial resources to keep them alive, and of course ongoing discussion of the permissibility of withdrawing life support, which seems to dominate the bioethical discussion about these patients. And I think it's really striking that these persons have not only been set apart from the general population or the healthy population, but also set apart from the population of all other people with brain injuries, so that we sort of have these two broad diagnostic and ontological categories, disorders of consciousness and brain injuries, and of course what distinguishes them is consciousness. It's interesting that so much import should hang on something that we have not fully defined or that we do not even fully understand at this point. I think it's also interesting, as Dr. Finn sort of alludes to, that all of this begins to happen historically at about the same time that brain death was defined, and that was in response to another group of hopeless cases, the irreversibly comatose, about whom the right to die issue was actually bypassed entirely by just declaring that they are in fact already dead. And I detect some drift between attitudes about brain death as medical and legal orthodoxy and the vegetative state, which is commonly perceived to be a kind of death or as good as death. So by definition, as you all know, someone in a VS is unconscious and not aware of themselves or their external environment. And by definition, there's nothing going on inside. There's nothing it's like to be a person in a vegetative state, and nothing it feels like. And that empty existence that we presume is there is perceived by many to make life in a VS worse than death or equivalent to death. And there are actually also those philosophers who argue that the permanently unconscious person is dead, or should be considered dead, because to be a person requires that you are conscious. Now, on that view, there are no persons in a VS. They should be filed in the category of the dead, and which I suppose also means there's no VS, so some of you are out of a job. There's been a couple of interesting studies recently, one about public attitudes of the VS and one of family attitudes about a relative in the VS. And it's very clear that patients are commonly perceived to be at best ambiguously persons. So many people actually ascribe less mind to persons in the VS than to the dead. And also viewed the VS as being highly aversive, despite the fact that they're basically dead, as being worse than death, but dead. Many family members also sort of view their loved ones as being both dead and alive, not straightforwardly alive and not exactly dead either. And when I talk to people, of course, it's not at all unusual for them to confuse brain death and the VS. So I don't think people here are going to do that, and I don't think doctors and scientists and most philosophers confuse the two. But it's apparent that, that there's at least some moral equivalence between brain death and the vegetative state for some people. So corresponding to relocating people with disorders of consciousness beyond the borders diagnostically and ontologically has been a kind of moral relocation where they are viewed in a very different light than others with brain injuries. And as you all know, of course, and as many of you have contributed to this knowledge, things have changed. So the diagnostic categories of docs have been redefined and refined a great deal in the last decade, and they're continuing to be further refined as more is understood about disorders of consciousness. The idea that they're all hopeless cases is certainly wrong, as Dr. Finns points out, and there is an unacceptably high rate of misdiagnosis. So it's fairly certain that a quite large number, around 40%, of patients diagnosed as vegetative are misdiagnosed because they show no behavioral evidence of being consciously aware. And they're not misdiagnosed as being alive when they are in fact dead. They are misdiagnosed as being unconscious when they are conscious, possibly minimally conscious, possibly more than minimally conscious. So there's this false negatives problem. There are people who are covertly aware and who can demonstrate, perhaps by willfully modulating their brain activity, that they're conscious, that they're in there. And from that, we should minimally infer that there must be others, including others that we still can't reach, others who still have no way of telling us that they are in there. But because the absence of conscious awareness cannot be determined with the same degree of certainty as its presence, so the absence of evidence is not evidence of absence, having certainty that some doc patients are covertly conscious means that we are also in this new age of uncertainty. So the false negatives problem is still there. It may be worse than we knew. And the diagnostic and prognostic waters have been troubled. And so too the ethical waters and the legal ones by this new certainty and uncertainty. So there's great legal and ethical uncertainty as both bioethics and the law have not yet really reckoned with the minimally conscious or with the covertly aware. The bioethics discourse, as I said, is still very much dominated by variations on the end-of-life arguments, often applied to specific cases that come up in the courts. So an important ethical implication of the uncertainties is that our old certainties about these patients, our bioethical and legal dogmas about disorders of consciousness, must be questioned. And the first dogma is that as a class, patients with disorders of consciousness are distinctly different, both from the healthy population and from others with brain injuries. They're different because they're not conscious. And I don't think there's been a lot of pulling apart of people who are in a vegetative state and minimally conscious in the ethical discourse so far. Of course, we shouldn't have the same level of certainty that we used to about the absence of consciousness of someone diagnosed in a VS. That uncertainty should prompt us to pull them back inside the margins and to start thinking about people with disorders of consciousness as people with brain injuries, because they are people with brain injuries. So inclusion there is morally important because their separation from that class has resulted in the contested moral status of people in disorders of consciousness and that second dogma that consciousness matters to moral status. So inclusion in the spectrum of brain injuries would mean moving beyond discussions about end of life or the value of life and thinking about some of the same concerns that apply to other people with brain injuries. And one that's ethically significant that I want to talk about in some detail today is this issue of quality of life. And there again is an area where dogmas tend to dominate, one being that quality of life is necessarily bad or necessarily absent, and that there's some gold standard, right, the quality of life of a healthy exemplar, and that being unconscious or minimally conscious results in a drastic reduction in quality of life. So coupled with this folk idea that there is something extremely aversive about permanent unconsciousness, which can make it on balance worse than death, this dogma fuels the debate about the withdrawal of life support from persons in the VS. So we see this same dogma and some attendant confusion in the legal realm, where the VS is viewed again as highly aversive, such that life either has negative or no value for the VS person. So this idea that the VS equates with really poor or overwhelmingly poor quality of life that makes it in the best interests of patients to withdraw life support, patients about whom there is at the same time doubt about whether they have any interests if they are in fact unconscious. So this quote from Justice Stevens in the Nancy Cruzan case really captures some of these concerns and the assumptions about the vegetative state. So he says, if she has any awareness of her surroundings, her life must be a living hell. But he also points out that it is appropriate to consider quality of life in making decisions on behalf of these patients. The courts have been far less certain and wrestled with what to do about or for patients in the minimally conscious state, patients who are conscious. And there they seem to have set aside quality of life as a measure of individual interests to focus on something like the bare value of life for someone who is conscious. So in the Wendland case, right, they point out that he's conscious and maybe he wants to continue to live, so he must continue life support. So consciousness carries a lot of weight, both in the law and in ethics. So in the interest of full disclosure, I'll admit that I am one of those bioethicists who worries that being minimally conscious could result in a really bad quality of life. And I think we should be concerned about the quality of life of DOC patients, but not in the sense that we should continue speculating and making uninformed assumptions about their quality of life. We do need to learn more about their actual quality of life. And we may be at a moment here, I hope, where neuroscience can actually contribute some information to that place where we don't have any information at the moment. So since so much ethical import is attached to quality of life, I want to discuss how quality of life might be ethically used in thinking about and making decisions for DOC patients. So quality of life is this broad, complex concept about which there's very little consensus, either concerning the definition of it or the factors that influence it. There's a lot of different ways that we might measure quality of life. It's certainly one of those concepts that we all intuitively understand, and figures prominently, although sometimes covertly, in bioethical discussions related to disorders of consciousness. There is consensus that it's inherently subjective and refers to the subjective experience of an individual and should be assessed from the perspective of the individual relative to his or her own values. The challenge of assessing quality of life is to quantify what is inherently qualitative and subjective, and so to measure sort of what it's like to be. And there are many instruments for doing that. All of them try to objectively quantify this subjective qualitative state of being. Most of them use self-assessment and self-report on the part of patients, which presents particular challenges for assessing people with brain injuries who might have deficits in their ability to communicate, as well as in their self-awareness and self-insight, which can impair self-reporting. So for obvious reasons, this is especially acute in patients with disorders of consciousness. It remains empirically unresolved how reliable brain-injured persons are as self-reporters, although research shows that actually a sizable percentage of the general population also encounters difficulty completing complex quality of life questionnaires. I'm not sure what to make of the doubt about the reliability of someone's self-report and their self-assessment of their own subjective quality of life, as if someone else could have a better assessment of it. But there's obviously interesting questions related to that. One of the shortcomings of instruments that measure quality of life in patients with brain injuries is their insensitivity to certain domains that might be more important to people with brain injuries as opposed to the general population. So people with cognitive and communication deficits or chronic pain, obviously those things have significant impacts on your quality of life, but some of these instruments are not very sensitive to those kinds of domains. Existential well-being, successful readjustment of your life perspective, feelings of estrangement from yourself or from others, isolation, and things like that, intimacy, relationships with loved ones, those can all be more important to someone with a brain injury when other areas of fulfillment are no longer available to them. So these generic quality of life instruments are not very sensitive to the needs of people with brain injuries. And generalizing from the general population to persons with brain injuries is problematic in quality of life assessment. So an obviously important area of improvement would be to develop a better and richer understanding of what quality of life is like for people with brain injuries in general. But there are some important insights that we might gain about quality of life and disorders of consciousness from other people with brain injuries. So one of these is response shift, where people who have an acquired disability can sort of recalibrate or reprioritize their values. Response shift can result in people sort of coming to accept a quality of life or accept a life that they might have prior to their injury thought would have been unacceptable. It may be an explanation for the disability paradox, where people with serious disabilities report, contrary to expectations, that their quality of life is actually good. So I think Terry Wallace is an example of someone who, contrary to the expectations of many, says his life is good. He literally says his life is good. The disability paradox is not, of course, a true paradox. There's nothing logically inconsistent or impossible about someone with a disability enjoying a good quality of life. It only appears paradoxical because they confound the expectations of others when they have a good life and adjust to a life that others would consider not to be anything but horrible. So the real mystery here is really why there's such a persistent belief that quality of life is poor for people with disabilities, despite so much evidence to the contrary. Response shift might also explain why caregivers and proxies often rate the brain-injured person's quality of life much lower than the person him or herself does. So proxy informant reports of quality of life are also questionable. So as an example, as I think Stephen mentioned earlier, patients in the locked-in syndrome the large majority report that their quality of life is quite good and comparable to the quality of life of healthy controls, and a small minority report being quite miserable. If nothing else, these kinds of results show that even profoundly disabled brain-injured persons often confound expectations about their quality of life. The same might not be true of patients with disorders of consciousness, but generalizing from other brain-injured persons emphasizes the need and the ethical imperative to learn more about their actual quality of life rather than relying on population-based norms or preconceptions or proxy reports. So there are no quality of life instruments for assessing DOC patients. There's skepticism about the possibility of measuring their quality of life when you're unconscious or in a minimally conscious state. It's not known what it's like to be in a state of unconsciousness, certainly, or if they experience anything at all. So it's conceivable that some might not be aware of anything that we might recognize as a lived experience with a subjective quality. So one of the tragedies, I think, of being permanently unconscious would be that there is nothing it's like to be alive. There's nothing it's like to be you. There's nothing that's in your interests. You have lost everything that might have been of value to you. But this sort of negative value that's ascribed to the VS is negative from this external point of view, from the point of view of people outside of the vegetative state. And no one in the VS has recovered and been able to report what the VS was like, at least no one that I know of. So given all that, does quality of life matter? Well, it matters because withdrawing life support from persons with disorders of consciousness has given rise to decades of legal and ethical controversy, but more importantly, it's a source of real anguish for families who are faced with making decisions on behalf of their loved ones. Frequently fueling these debates are implicit assumptions about the value of life in a state of impaired consciousness and a lot of persistent uncertainty about the burdens and benefits of treatment and life support. So people contemplating end-of-life decisions have an urgent need for answers about quality of life. They want to make informed decisions on behalf of these patients. It's also important for therapeutic decisions. For example, does someone have a need for pain relief? Does someone have a need for environmental enhancement? This is a highly vulnerable group. They're unable to consent to treatment or to research participation. There are ethically serious reasons for worrying about subjecting these patients to treatment or to research. They can't consent, they can't assent, they can't voluntarily leave or dissent. And their proxies need information about the burdens and the benefits in order to make decisions for them. And quality of life is a really important outcome, right? It's a metric for assessing the success or failure of therapeutic and experimental measures. So we should try to find out, if we can, how someone's life is actually going, not how it measures up to some pre-injury or some healthy exemplar. So here I want to just speculate and be hopeful a little bit that, that we might have a way to do that, that we might be informed a little bit here by some of the neuroscientific discoveries that we've made in recent years. And I propose this really minimalist and pragmatic model where we target negative affect and positive affect. Limiting these domains is really not grounded on a claim that this is all that matters in quality of life. For most of us, just positive affect and negative affect barely scratch the surface of what we consider important for our well-being and our flourishing. But these are fundamental to quality of life. They undoubtedly do matter, if anything does. And I think we actually may have some potential here to objectively assess these in patients with disorders of consciousness. So this is a model that's really based on a claim about what matters that we can at the same time assess. And here I'm thinking of patients who are covertly aware or who can't meaningfully communicate through any currently available means. So promising contributions from neuroscience that have emerged in recent years are discoveries about neural correlates of pain and pleasure. Tor Wager's work on neural signatures of pain and emotional distress. Evidence of pain perception and not just nociception in patients in the MCS. This is information about capacities for pain and distress or capacities for pleasure and enjoyment, which might allow us to make inferences about subjective well-being in individuals. And clearly, we also want to know things like, can this person hear or see? Do they have any access to the external world? I don't want to be overly reductive here and say that correlation equals certainty in neuroscience. Having a capacity for pain is not the same as being in pain. Whether or not you are in pain is what matters to your quality of life. And likewise, a capacity for pleasure or enjoyment matters not at all if you don't actually experience pleasure or enjoyment. So capacities and neural correlates don't give us certainty about an individual's subjective quality of life. And I don't think we're going to construct some kind of moral certainty out of this either. But, you know, as they say, don't let the perfect be the enemy of the good. We don't have a perfect measure of quality of life in anyone with a brain injury. I think we might be able to chip away, though, at some of the uncertainty that exists right now. So there's already really important research that's being done on these patients on experimental therapies, although I think we lack the ability to assess how those therapies will affect their subjective well-being. So we need quality of life information as a part of justifying those other research agendas in order to judge the benefits and the burdens of that research. And in the absence of paradigms for doing that, before and after therapeutic interventions, I think we risk, in some cases, worsening their plight in ways that would be ethically unacceptable. So having some notion of what life is like for these patients, and that might include data from other patients with similar injuries, might inform our treatment decisions and our research decisions. It also might help guide the way towards developing treatments and rehabilitative strategies that are responsive to their actual needs rather than just their presumed needs or the needs of others. So this is research that has the potential to directly benefit some of these patients by providing evidence of the need for pain relief, for example, or prompt the provision of positive and enjoyable stimuli. One more way that I think this is ethically important, and that it's ethically important to reintegrate patients with disorders of consciousness into the fold, is and to treat them like other people with brain injuries is regarding questions of consent and autonomy. So of course there's a great deal of diversity among people with brain injuries. There's a spectrum of cognitive and functional disability. And needless to say, patients with disorders of consciousness would tend to be situated at the severe end with significant or near total functional and cognitive disability. But their autonomy and their consent is proxy mediated, as it is with others with brain injuries. So it's important that their proxies actually have relevant information when they make decisions on their behalf. So the final dogma here is shared by bioethics and the law, and it's that quality of life is appropriately and ethically used as a measure not of the subjective well-being of the patient, but for comparatively and objectively assessing the value or the non-value, and that includes the economic value of interventions, including life support. That is, we don't need to worry so much about the quality of life of a presumably unconscious person. We either assume it's really bad or worse than death or non-existent, but we can use those assumptions to provide kind of backdoor illicit support for terminating treatment or for withdrawing life support or, even in the case of just denying coverage for treatment. I'm not arguing that it's always wrong to withdraw life support. I think we should respect the rights of individuals to make that choice for themselves through advance directives or through informed proxies who understand their preferences and their values. But I am concerned about making blanket statements about the value of life for all of these patients and treating assumptions about their quality of life as certainties and using the supposed certainty of unconsciousness to undergird claims about the objective value rather than the subjective value of providing treatment or keeping them alive. So in the absence of reliable and valid information about quality of life, decisions are made based on unsubstantiated beliefs about the subjective value of life for these patients, on suppositions and preconceptions that we actually have good reasons to question. And that denies these persons what little proxy-mediated self-rule actually still remains to them. So there's an opportunity here to change that and to seize on this golden age of uncertainty that we are in right now and to challenge these dogmas. And to, I think, give these voiceless patients some measure of control and to help us reach some small distance across the abyss that separates them from their families and their community and also the rest of the world. Thank you.